Good afternoon, everyone. I'm delighted to welcome someone who is not only a world-class expert, but also a familiar face to Kekesh, Dr. Don Kikkawwa. Dr. Don is a distinguished professor at UCSD and serves as the executive vice chairman and the chief of the Oculoplastic surgery. He co-founded the UCSD Oculofacial and Thyroid Eye Center and has earned numerous recognitions, including the American Academy of Ophthalmology Lifelong Achievement Award. But what makes this moment special is that Dr. Kikkawwa is truly returning home. In 1993, he worked here at Kekesh, and he lived in Villa 42, which he went there yesterday and took some photos, creating memories and relationships that still resonate with many of our staff to this day. We are honored to have him back with us, so please join me in welcoming Dr. Don Kikkawwa.
Thank you very much, Dr. Osama. It's a very kind introduction, and it does feel like homecoming. So I'm going to be speaking today on a couple topics. The first one will be on precision. Here are my disclosures. So we'll talk about what is precision. We're going to talk about precision in oculoplastics and maybe how it's helped us with diagnosis, therapy, and talk a little bit about education. So this is a diagram of bullseye target, and probably most of these shots are not hitting the bullseye, but they are precise because they're actually hitting relatively consistently. But we don't know how precise we need to be in ophthalmology, particularly oculoplastics. If we look at medicine in general, if we look at lab values, for example, most of the lab values fall within this 95% confidence level. But I would say probably with surgery, we don't want to be in the 95th% confidence level. Our spread needs to be a little bit tighter. So for example, glucose, the range is about 80 to 130, which includes most of this bell-shaped curve, but we want to be as close to the middle as possible. For example, on ptosis, I guarantee you're probably not going to want the 95th% confidence level. So we have to try to strive to provide the highest level of care for our patients. But this just goes to show you how far off you can be and still be successful. So how many of you remember Apollo 11, maybe before many of you were born? The moon was 240,000 miles away. How close do you think they got to their target landing spot? They were 4 miles away from where they wanted to land, but it was still a successful mission. How about the Hubble telescope? You remember the Hubble telescope and how they spent billions of dollars to try and get a focused image? They were able to correct it, but the first images that came looked like the ones on the left. How much was the mirror off at the Hubble telescope? 2 microns, and the cost was $1.5 billion to correct it. In medicine, we see that there are some errors, limits of errors that are acceptable. For example, fractures, you can probably be off a couple of millimeters. You're not going to see a huge difference in the result. What about with this type of lens you put in? How much can you be off? Not much, microns. So for our field in oculoplastics, we have very few objective measurements, right? We have MRD, which is the margin reflex distance, which is the distance between the light reflex and the lid margin. We have exophthalmometry. We have canthal distance. We tend to use terms such as overcorrected, undercorrected, looks good. These are the terms we use to describe what we see. How many of you ever put looks bad on the chart? No. Okay. So until we start measuring things, we don't really know if we're advancing the specialty. So if you don't measure it, we really can't improve it. Well, we know ptosis has been with us for quite a long time. It was seen back in this old photograph. One of the kings, King Edward, had it. And then nowadays with social media continues to be noticed, even very small amounts of ptosis. If you look at the lid position does have a normal contour. So most people think it peaks right in the pupil, and the lowest point of the lower lid is at the pupil. But if you look at this normal eyelid, look, where does the upper lid peak? It peaks slightly nasal to the pupil. And the lowest part of the lower lid is actually temporal to the pupil. So there is a little bit of asymmetry. And if you really look at putting the peak and the lowest point of the lower lid at the mid-pupil, it actually looks a little different. So we have to train our mind to think differently when we look at these contours. So I think for us in oculoplastics, we try to figure out which procedure to do. And for those of us who do this type of surgery, there's really kind of two different approaches. One is the posterior approach, which could include a muleirectomy or white line advancement, fascinella, or there's also the anterior approach where we perform external levator approach, and sometimes we can perform concurrent blepharoplasty, which helps with the skin. The main endpoints of what we see with surgery really consists of three things: lid level, contour, and symmetry. So for the outcome of lid levels, we really still are kind of stuck with this MRD. Well, what's the problem with MRD? It really just looks at one single midpoint measurement, right? We're looking at this single distance from that light reflex to the lid margin. It has not, we talk about temporal flare, temporal droop, but are we actually describing the distance? No, it's more of a qualitative value. This is a patient who had preoperative ptosis on the left. She underwent an anterior levator resection, and you can see right at about 2 weeks, she's not looking that great. Her lid is still a little bit low. And then I think we have to maybe think in our own mind, well, do we revise this at 2 weeks or do we wait? So we sat this one out, and we saw it a couple weeks later. Here she was. So there was some improvement. Contour and symmetry usually play into our management of patients when we have bilateral surgery. We might be performing bilateral ptosis repair. This is a posterior approach patient who had conjunctival muleirectomy. And you can see to the naked eye, the result looks pretty good, right? There's good symmetry, there's good level. And the contour, I think even though we don't have a good definition of what contour is, you would say probably the contour is pretty good. Contrast that with this patient here, where we look at the level and symmetry and contour of this patient. So this is an anterior approach where we're actually making a skin incision and we advance the lever from the anterior approach. So is this a good result? I would say it's a good result. Is it a perfect result? Why is it not a perfect result? The left upper lid is just a little too peaked. If you look at where we talked about earlier, where the teak of the upper lid should be nasal to the pupil, this is slightly temporal on one side. So it's not perfect, but it's good. Patient wasn't complaining about it, but I think these are the types of things we have to notice internally when we are critical of our results. And why did this happen? Probably the upper lid suture was a little bit too far temporal. So how do we get more precise with our measurements? It was a big lead up into this one question. Putterman was the one who described MRD. And MRD is a central midpoint measurement. MRD1 is the upper lid level. MRD2 is the lower lid level. This really is the gold standard. So when we record it in our charts, I'm sure you are all putting down the same measurements. But it doesn't really talk about contour. So we took this into consideration when we were looking at an eyelid contour analyzer. So we had one of the benefits of being at our universities, we have access to computer programmers. So this was all pre-AI. So we actually did iris recognition, and we had our programmer program iris recognition to detect the iris on photographs, and then it would draw the contour of the lid. I think nowadays with AI, you could probably get this done very easily, and some of the papers that are out there do this. But the thought at the time when we developed this was that we would take a picture, and then you can see the iris gets detected, and then the computer program actually draws the contour of the upper and lower lid margins. It's not 100% exact because you can see kind of the measurements are slightly off. So there is a chance for manual override. When the contour is slightly off, the program did allow us to adjust it and get a pretty good contour of what the lid is supposed to be. And then what we were actually doing was collecting a database of normal contours. So how this fit into play with us is that we would calculate the best fit curve of the eyelid. So rather than looking at a central midpoint measurement, it would look and see, this is comparing the lid to multiple other eyelids in the same gender and age range, and then it would come up with the normative measurements. So the contour in red is a average of all the blue contours of a similar age and gender. So this was a way how we could show a photo of someone who had a normal lid contour compared to what the others were at that age. And you can see they're pretty close. So it takes a little bit of manual interpretation as to what you would consider away from the normal. So how did we actually calculate the difference? We use standard deviation. So if you look at the person's lid in blue, the red would be normal for their age and gender. So the difference from the mean was actually measured in standard deviation. So rather than looking at this 95% confidence interval, the lower the standard deviation, the closer you were to that midpoint. So it's just a different way to look at things. And where it really comes into play is when you see really abnormal lids. So this is a thyroid eye disease patient. Red is the normal contour for that patient's age and gender. And you can see where the upper lid contour now is way off from the normal. So look at how many standard deviations away they are from the mean. So the upper lid is 1.62 standard deviations, which is way off on the scale. Same thing with the lower lid. So it does give a different way to look at contour. I think for clinical use, what you can envision is that you would have an overlay like this where you can show the patient, well, this is what your lid looks like in blue, and for a normal person of your age, gender, ethnicity, this is what the contour looks like. So it's a different way to think about rather than just MRD. So I think when we were examining this, we were still in the process of collecting patients to come up with a normative database. And then when AI hit, we had to shift gears because you don't necessarily need to, you can train the computer model to detect this. You don't necessarily need to use iris recognition. So we never quite got that far until AI hit. But I think this type of project is still valid and useful because it helps to give us a different way to look at lid contour and lid levels. Let's talk a little bit about targeted agents. So there's been huge diagnostic advances in how we diagnose clinical disease, mainly based on cell markers and cluster of differentiation markers. So this is a patient who actually presented with what looks like orbital cellulitis. You can see he's got a swollen upper lid, lower lid, very proptotic eye. If you look at his ocular surface, he's got chemosis. Frozen globe, up gaze is bad, down gaze is limited, medial lateral. He started to develop also these ulcerated lesions. So he's got one in his lower lid. He actually has some forming in his mouth. So this is probably not a standard orbital garden variety cellulitis. Something else is going on here. On imaging, this is what his scan looks like. So you see he's got large lateral rectus, medial rectus. The tendon is involved. He has soft tissue infiltration of his medial canthus, lateral canthus. Even the sinuses are involved. Prior to the advent of these cluster differentiation markers, cell markers, this is what used to be known, if you look at some of the older textbooks, this was called lethal midline granuloma. So this patient did very poorly and ended up succumbing to his disease. The diagnosis was always thought to be, syphilis, some sort of fungal disease, very destructive tumor. We did do a biopsy on this patient, and this is what the slide looked like on histopathologic markers. This was positive for CD56. Anyone in the audience know what CD56 is the marker for? It's the natural killer T cell. So this is what's known as NK T cell lymphoma. So this is the type of diagnostic accuracy you can get with these, what used to be clinical patterns of disease are now very clearly delineated. So this patient, again, was not able to be treated with standard means. NK T cells are very highly progressive and can be lethal, but CD56 aided in the diagnosis. So what about targeted? So that's with diagnostic accuracy. What about with treatment? So once we are able to identify the marker, we actually might have some treatment for the disease. So this is a gentleman who presented to me with ptosis. And as we tell all of our residents and fellows who examine someone like this, you have to flip the lid when you see someone like this. So measure the levator function and then do a thorough adnexal exam, make sure everything is okay. This is what the upper fornix look like. So you'll recognize this as the salmon patch of another type of lymphoma. So this is we did biopsy to diagnosis. This happened to be very strongly positive for CD20, which is the B cell marker. And as you all know, rituximab, which is probably off patent now. This is probably one of the first monoclonal agents that was ever available for pharmacologic use. So it's a monoclonal antibody directed at CD20. This is the patient before and after 3 cycles of rituximab. So that's one example of targeted therapy. Thyroid eye disease has given us other targets that we can treat for targeted therapy. So as you know, thyroid eye disease is a very complex autoimmune process that targets the orbital fibroblast. This is a diagram from Terry Smith's pioneering work. All these surrounding cells produce antibodies, interleukins, cytokines. They attract other mononuclear cells. And the antibody attack is located here in this orbital fibroblast. The co-stimulation of the IGF-1 receptor and thyrotropin receptor create hyaluronic acid deposition and adipogenesis. And this leads to the buildup of tissue behind the eye, and you get this bulging phenomenon. So some of the general autoimmune treatments are nonspecific steroids can be given, steroids, cytotoxic agents, as well as biologic disease response modifiers. In the past, this was largely treated with steroids. So we gave IV steroids as an example of pulsed IV steroids. You can see this patient actually had quite a bit of improvement. This is 3 doses of 1 gram of methylprednisolone. Some of the problems is that this can cause liver toxicity. Even higher amounts can cause to liver failure and death. Radiation can be used. 2,000 centigrade is the dose that we usually use for thyroid eye disease, and this can be given in addition to steroids. Some doctors do oral steroids as a therapeutic trial, and if patients respond, then we will give them orbital radiotherapy. So one of the possible targets is tocilizumab that goes after IL-6. So if you think about this cascade of autoimmune processes, one of the cytokines that gets produced, IL-6 is a very powerful one that drives the autoimmune process. And it's FDA approved for rheumatoid arthritis, as well as giant cell arteritis. It's off-label for thyroid eye disease. Very significant paper, I think, that drew everyone's attention to IL-6 as a possible monoclonal treatment was back in 2014 by Moraes. Retrospective study in 18 patients. CAS, which is the clinical activity score that we use to monitor the activity of thyroid eye disease, was reduced in 100% of these patients. So this is a patient who had difficult thyroid eye disease. She's a 58-year-old female, underwent decompression elsewhere, came to us, also had IV pulse steroids. You can see her orbit is still very hot. She has a high clinical activity score. Look at how red and inflamed her eyes are. Even the tone of the skin surrounding her eyes is very red and inflamed. She has very limited ocular movement on right and left gaze, and up gaze is limited. This is her imaging. So this is a CT scan. Every muscle is enlarged, even the lateral rectus on the right side. So this is on the axial scan. You can see this is her prior decompression, so the muscle is actually prolapsing into the sinus cavity. And then on the coronal scan, you can see a huge inferior rectus, medial, superior lateral, and even the oblique is slightly enlarged. Less lateral rectus on the left side. So this is the target area of where the interleukins come into play. So we have T cell, B cells. These create these interleukins, which draw in other mononuclear cells. They also affect the orbital fibroblasts. So IL-6 is located in this box here. This is the patient before and after tocilizumab treatment. So you can see there's been a marked reduction in the inflammation. This is not a retouch photo. This is just the color of the skin. Just that much inflammation has been reduced. And then look at the amount of conjunctival injection reduction. So IL-6 is a very potent inflammatory marker, and that can be targeted for reduction of inflammatory disease. The other agent that we have is teprotumumab, which is another targeted therapy for the orbital fibroblasts. This targets the IGF-1 receptor on the fibroblast. This is a patient who had treatment with teprotumumab showing the pre and post inflammatory reduction. 6 millimeter proptosis reduction on the right, 3 on the left. Some minor side effects of cramping, monitored audiogram was stable. So the last part of this talk, I'm going to shift gears a little bit and talk about precision in education. So in residency education, we have a great foundation of all the subspecialties, and there is a board certification in the US that we have. Here you guys use the FRC? Is that what's used for, or do you have a separate Saudi board? Saudi board, okay. So there is board certification at the resident level. However, in the US, we don't have subspecialty boards in the subspecialties. So we know that subspecialization is very needed. It takes care of patients with complex problems. We have societies that allow focused sharing of information, journals, papers, but unfortunately ophthalmology, at least in the US, is one of the few fields where we don't have subspecialty boards. So, the topic of this part is how do we best provide education in this aspect for the next generation? And what aspects are needed to create the best learning environments for future MDs who want to specialize? And our future is really dictated by those who follow us, not necessarily us who are practicing the field, but how are we training the next generation? So just a little bit of history about oculoplastics. It really was a specialty that formed out of need. So back in World War I, 1919, I think was when it ended, the advanced care that was provided on the battlefield, unfortunately, was not great, and many of those soldiers died on the battlefield. With World War II, there was better survival, and after the patient survived their initial injury, many of the non-lethal injuries started to need care. So injuries to the face, to the eye, a lot of devastating facial injuries. So in the late 40s and 50s, there was some ophthalmologists that were interested in the eyelid and the orbital problems that occurred primarily out of need, because these patients were severely injured, and we needed specialists to care for them. So the specialty's come a long way since it was established in the mid-1900s. The modern oculofacial surgeon has to be not only a good surgeon, but has to be a detective, a technician, artist, technology whiz, and an ambassador with other specialties. I think probably out of all the ophthalmology specialties, we most likely interact with many of the other fields. For example, neurosurgery, ENT, endocrinology, dermatology, because the areas of the face that we deal with cross over so many different specialties. Maxillofacial surgery. Most of the fellowships after ophthalmology are 1 to 2 years. Retina's 1 or 2 years, cornea is usually 1. These are US standards. Glaucoma is 1, peds 1, neuro 1. Oculoplastics in general is a 2-year field. Why is that? Well, because I think the breadth of the diseases that we see and the rarity of some of the complex cases are just so few that you really need that longer incubation and exposure period to get adequate training. So why do we train oculoplastic fellows? Well, it fills a need for care of complex periocular problems, elevates the standard of care, helps the patients. And for those of us who do teach, it does take patients' time and resources. And I have to say, out of over the 30 fellows that I've trained in my career, it's one of the most professionally rewarding aspects. And I don't think, if I didn't have the interest in training, I think my professional career would have been much less satisfying than it is. So I really have to, the fellows always thank me for what I invest, but I have to say the reverse is probably more true, that I get the reward. So let's talk a little bit about our fellowships in the US. They're 2 years. They're concentrated in anatomic areas, including the face, eyelid, lacrimal system. And then the disease process is very broad. So there's trauma, infections, aging, tumors, and cosmetic issues. It's almost like a direct apprenticeship. So in the US, they require that the fellowships have to be directed by a single person. So that doesn't mean they have to spend 100% of the time with that preceptor, but the ASOPRS fellowships are under direct direction of one person who has to be involved with a majority of the fellows' training. And my philosophy of teaching is there's probably 2 ways. One is you first learn by watching, right? You watch someone do a procedure. And then the second would be you do the procedure. And then probably at the end, you can learn just by watching again. But I let the fellows hold the instruments. I let them expose the tissues. I give verbal instructions during the case. Certainly, I take over if needed. It's a little different than maybe with cataract surgery or something where it's irreversible. If I see a suture that's put in that needs replacement, it's easy just to cut it out and put another suture in. So for us, it's probably a little less stressful than someone who's doing intraocular surgery where you have irreversible steps. For us, most of the time, it's reversible. If we have bilateral cases, I usually do one side, they do one side. They see patients pre-op and post-op. They're not in surgery all the time. Some of the fellowships they do surgery 5 days a week. And I think that you do need the pre-op and post-op visits because a lot of the learning goes on at that time. One thing that I try to do is meet after every clinic. So we have our clinics, we review cases, and then we look at before and after, just like I showed you on those ptosis patients where we look at the results before and after. We look at them and we have monitor and we say, well, why is this a good result? Why is this a bad result? Fellowship mentoring, I think, is very similar. Since I have Japanese ancestry, there was a trade that was passed down in Japan, which was the making of the samurai swords, and it was something that occurred over. You couldn't learn this in 1 year. This was like a 10-year apprenticeship. So oculoplastics is only 2 years. It's not 10 years, but it does, it's passing down of an art, but it does leave room for creativity. I try to maintain contact with all my past fellows. They are free to contact me with any difficult cases, and I certainly want to see them succeed and do all I can to help, and I consider them as family. So what are we actually teaching? Well, knowledge. We have an in-service exam, so this is done for the ASOPers. They have, every year they give a standardized test that's graded amongst their peers, so they take this as a first year and second year fellow. They have percentile ranks, just like the OCAPs, where they're ranked amongst their peers. And then we have core knowledge that we have to disseminate, and this includes journals and journal clubs. I know you guys run a journal club which is great. Procedures, so we do procedures that are all documented and proctored by attendings, and we keep logs, only those with that are proctored by an attending count on the log. We also have a clinical pathologic conference where we present interesting cases. We show the clinical part. We invite our pathologists to opine on the pathology, and then that creates a good dialogue between the pathologists. And then all the residents and fellows and attendings attend this conference, and it gives a good chance to see interesting cases. Probably the most important part that we teach, that I try to teach, and this is one of the hardest things. How do you teach professionalism? You know, professionalism is one of those things I think that is probably something we all have to model ourselves, and hopefully the trainees will see us act in difficult situations, and they'll kind of mirror what we do. So this involves ethics, sensitivity, compassion, integrity, responsiveness, and accountability. You know, some of these things again, how do you teach this? Responsiveness, I think, is one of those things where you get a call from one of your colleagues, you know, you don't put it off to the end of the day, you call them back as soon as you can. And those are the types of things that I think we can model. They're very hard to teach, and they're very hard to grade. So I see that some precision in education was noted in in your trainees. We had Dr. Iman Al-Sharif with us. Nothing is more satisfying than seeing one of your former trainees get up on a podium in front of 800 people and give an outstanding talk. And then we look forward to having Abdul Rahman also for the next couple of years. So that's my spiel on education and precision. I purposely ended this a little bit early so I can take any questions. So we have seen advances in precision in measurement and in therapy, and they've ranged from molecular diagnostic to targeted therapy. There are some key points of precision in education that we covered. There probably is a lot more. And then when these highest levels all intersect, we get the best possible patient care and the best possible doctors who will take care of future patients. So thank you very much to Kikesh for the invitation.